Hey, good afternoon, everybody. I am Drew Armstrong. I'm a healthcare editor at Bloomberg News, and I'm here with Vivek Garipalli, the CEO of Clover Health. We are going to talk about healthcare, and I had a kind of carefully curated plan this morning to talk about all sorts of interesting things about insurance. And then around sometime after I'd had my coffee, one of my reporters screamed at me from across the room. They said, the J.P. Burkazon thing is happening. And we ended up crashing and spending most of our day trying to figure out what Jeff Bezos, Warren Buffett, and Jamie Dimon are going to do in healthcare. So I wanted to quickly start this off with a really quick poll here. For folks who work at companies or folks who run companies and have to think about, how much are you spending in your contribution to healthcare premium? Does your employer do a good job of keeping your costs down? How many of you, just knowing and thinking about this thing, three giants of business who are going to come in and have this big hire that they're going to do a tool go on it, how many people think this thing has any chance of getting healthcare costs in the US or for their clients? And I'd just like to see a show of hands here. Anybody optimistic? A couple folks? Maybe 10 people. So I think that kind of reflects a lot of the frustration that people deal with in healthcare costs around this country. And I want a chance to talk to Vivek about, you sit in a really interesting place. You run a company that has Medicare coverage for, about 31,000 people, I believe. Yep. And, you have 500 employees, so you're not only a provider of healthcare, you're also a purchaser of healthcare. And you sit on the side where, you and other employers essentially, who sit in a similar position, you're having to buy these services or pay for these services or kind of the financial endpoint. And on the very other end, we have patients. And in between, we have this kind of vast network of doctors and hospitals and drug distributors, pharmaceutical manufacturers, drugstores, pharmacy benefit managers like Express Scripts. And we have this incredibly complex system here in the US that I think has been, despite the consolidation we're seeing right now, has really been resistant to a lot of the change. This is a conversation you and I have had over the last year or two, but I wanted a chance to ask you, when you look at the kind of structural way healthcare is organized, and as a payer, essentially, where is the kind of low-hanging structural fruit that we should be thinking about? Or what are the really big opportunities for people to get at systemic change? Or when we think about what is this, these three business luminaries who are going to kind of come here and do this with the help of a tool go on it, where are the really big opportunities for someone to come in and do something different? Or just places where you look and you say, that's completely insane. I do not know why we do this way, and it is screwing over all of us every day.
Love that question. So pulling out of Medicare, which is our focus, the thing announced today is obviously focused on the employer insurance market. I think the interesting thing about picking healthcare is there's a massive amount of, I wouldn't call it inefficiencies, I would call them structured inefficiencies, meaning the system has gotten to a point where business models have been built around some of these inefficiencies. So I don't think they're going to have a short list of areas of opportunities. I think it's a really long list. So we take like a couple things that folks may or may not be aware of that are non-intuitive in business but are intuitive in healthcare. Most people who operate a business or have worked at a company knows when you raise your price of your product, typically as the price goes up, your demand goes down, or people will seek services elsewhere. In the pharmaceutical space, if you want to increase the market share of your cancer therapeutic, you actually raise prices.
This is something that anytime we mention to someone, it absolutely blows their mind, and it makes no sense at all. So please explain a little bit about why this happens.
Yeah. So most therapeutics you are over the counter. You get them filled at a pharmacy. You take them at home, mostly oral medications. Oncologists, which are cancer physicians, are unique in the sense of a lot of the therapies that they administer are in the office, such as chemotherapy. So the way oncologists are paid, because they have to take the risk of the drug, so they actually have to purchase the chemotherapy from a distributor, so companies like a McKesson or AmerisourceBergen, and then they bill for the drug to get their dollars back for what they outlaid for it, and they have a markup, typically a couple percent under Medicare, Depends on the insurer, maybe 1, 2, 3, 4, 5%. So the more expensive the drug, the higher the dollars amount in terms of percentages. So typically if there's 2 drugs that are equivalent, you pick the higher cost one from the perspective of making a larger reimbursement. And from a physician perspective, you feel that it's still the same type of care and you're generating more margin on that.
And has anything really been done? I mean, is there a way out of this? I mean, what kind of, that's obviously a kind of perverse incentive, and we see perverse incentives like that in the healthcare system all the time. I mean, what does something that's designed correctly or that someone has figured out how to do, what does that look like? How do you fix a problem like that where, maybe it doesn't make that much of a difference to the patient, they're getting roughly an equivalent drug, but it's obviously impacting the finances of the healthcare system, which, all of us are feeling every time we pay a premium to an insurer, pay, tax dollars that go to fund Medicare and Medicaid. Explain, why, I mean, how do you solve a problem like that?
Yeah, so sometimes when there's intelligent solutions that get created, there's alternate paths that get taken. And so some payers have made progress on modifying the percentage markup to a fixed dollar amount, so to try to move that incentive out. And then what distributors have done is actually then they set up rebate programs. So if you purchase certain therapeutics or if you shift your purchasing, they'll just give you a larger rebate on that set of drugs. So maybe you're not getting it on the markup now, but now you're getting a large rebate check back. And so there's this constant adjustments that go on just in terms of how dollars flow in the system.
And I want to ask you, I mean, when we think about how a drug gets from, a manufacturer into a doctor or patient's hands, I mean, we have this, you've got the manufacturer who's going to sell it on to the distributor, who's going to ship it to a pharmacy, who works with a pharmacy benefit manager that contracts with the insurer. I mean, we have this very complex set of these middlemen. In this day and age, is that still necessary? I mean, you have a good insight to how complex a lot of healthcare can be, and sometimes by necessity. But when you think about how the supply chain exists, if you were designing this thing from the ground up, does this sort of arrangement still make sense? And is anybody doing anything about it to kind of try to displace some of these very entrenched players?
So I think on the governmental side, one of the challenges is today the U.S. government is not legally allowed to negotiate on drug pricing. So typically prices are set at levels at a high level, but typically not high enough to create public policy issues. And so it's really kind of a give and take around that. Where we see a lot of pricing opaqueness is on the employer side. So there's big pharmacy benefit managers that sit as middlemen. Essentially, they are a processing engine. When you have your health insurance, they're the ones interfacing with pharmacies to determine what drug is covered. Is it a generic? Is it a branded drug? What your copay is. And so the way these contracts are written, especially if you're a small employer, it's very, very likely there's probably a 20 or 30% margin that the PBM is taking. So imagine a distributor having 30% operating margins in any other business. But it's like that in the employer side.
And do people, just out of curiosity, I mean, do employers and insurers, do they know that they're paying those types of margins to their kind of their middlemen who are in this? I mean, is this something people are aware of and frustrated by, or is it, hey, this is just the way it is? I mean, what's the attitude around there about this?
So it's a total black box. So they can adjust they have the most complex contractual setups where if you negotiate lower branded drug pricing, or so let's say you negotiate lower generic costs, they'll put in clauses in the contract to reclassify what is a generic. So the definition changes, and certain things that are generic turn into branded, and there's higher markups around that. So it's imagine a legal document that you negotiate where your counterparty is an expert and they have a certain profit that they want to make. So if you negotiate one clause, another thing changes. And I think just a rule of thumb in healthcare, the more opaque the P&L is, the higher the EBITDA margin is probably the way to think about it.
Are there alternatives out there? I mean, I have talked to a lot of people over the years about the PBM system, and they voice similar complaints to what I hear from you. Is there anybody out there who, when you look at the kind of, contract environment, who you guys might work with, we say, hey, these guys are trying to do things differently, and they potentially have the scale or the ability to do it without us, having our patients shut out from being able to get into the drugstore and things like that. Does anybody really have an alternative system? We have a very concentrated market for these, if I recall.
Yeah, so I think in terms of this venture that where you've got Jamie Dimon, Bezos, Buffett, and now Atul Gawande focused on, that's a really interesting place for them to start, for example, because it wouldn't be difficult for them to create a nationwide network of independent pharmacies. They're creating a business model from scratch, so instead of creating a business model construct where they're getting a percentage of the drug costs, they can be transparent around pricing, around a flat fee to cover overhead. And so because they're not trying to preserve existing EBITDA, there's a way, if it's a ground-up business model, to actually do that. There's definitely a small set of earlier stage companies that are taking the approach of transparency on drug pricing and margin with employers. And I think generally speaking, in opportunities like that, if you're taking the approach of transparency, that should win, maybe not in the near term, but over a 5, 10, 15-year period in healthcare.
I want to change gears a little bit, talk to you about some of the stuff you guys are doing. You all, one of the strategies in Medicare Advantage is the government essentially gives you, I'm going to oversimplify here, but they say, you're going to take care of these 100 patients. We're going to give you a set dollar amount for each patient. It's your good job to go out there and do a good job of taking care of these people and do it in a financially efficient manner. Tell me about some of the stuff you guys are doing right now. I know you're starting to do some genetic testing of some of your patients to look into, is there a way of finding things out about them that are going to help you save money? Why don't you tell me a little bit about that?
Yeah, no, absolutely. So, just as a kind of a quick background, our population is in Medicare, so 65 and over, age-wise or disabled. And so as we've sort of spent a lot of time thinking about where our biggest impact can be made, it's really on the individuals that are the most at risk. So we have a small percentage of our membership that have approximately 8 chronic conditions on average.
And just so for the folks here know, 8 chronic conditions, this can be, they might have
congestive heart failure, diabetes, chronic obstructive pulmonary disease, asthma associated with that.
They're at the doctor a lot, they're on a lot of medicine.
Absolutely, seeing the primary care doctor 9 times a year, specialist 9 times a year, on average about 10 different medications. And so what we've learned, which is not an insight unique to us, the existing healthcare system, ecosystem, any local market is not set up to take care of that population well. If we think about physicians today, they have to see 20 to 25 patients a day. They get 10 to 15 minutes with each patient. They have to put food on their table to maintain that income level. And it's sort of what's happened in terms of the reality. So we started working with their existing physicians to actually move that patient population under our care. And so we partner with those doctors where we've actually hired our own primary care physicians in a home-based model. Because generally speaking, these are patients where they do find it difficult to get to a physician office consistently. And if you're not able to spend an hour or 2 hours with these patients at a time, it's really difficult to make an impact. So we've lowered the ratio to where it's 200 patients to one physician. And that in and of itself is not unique. There's definitely organizations that are doing it. The approach we're taking, though, is having it directly connected to the insurer. So we're the insurer, but also delivering this care at home as the physician. And you can personalize a lot of things. So one of the first things we rolled out is pharmacogenomic testing. So genomics gets talked about a lot as this next wave of data and insights. But we've tried to take a practical approach as to what is the use case of genomic data. So if you take the cholesterol machine, no one understands how a cholesterol test works. We just know you get a score, and your physician is able to take an action because of your cholesterol level. But with genetic testing, it's actually not well understood by most physicians as to what do you do with that data information. And
we can get information about all sorts of genetics that we have nothing, we can't, we can tell you if you're at risk of Alzheimer's, but we can't do anything.
We can tell you your genealogy.
Yeah.
And you have a 12% chance of getting this by age 80, whatever. But one of the really interesting use cases we found was around something called a P450 cytochrome. So this is a set of liver enzymes that regulate the metabolism of medications amongst other things. So just as a backdrop, 20% of hospital admissions are directly or indirectly caused by adverse reaction to therapeutics, to medications. And so those who are most at risk are those individuals who are on multiple medications, which is this chronically ill complex care population, and they typically have a lot of chronic conditions. So what we're able to do with this genomic test is identify if you have a variant in your P450 enzymes. And this variant, the way it promulgates, is about 16% of the US, of worldwide population, based on historical evidence, has some sort of variant of these enzymes. Typically, if you're on one medication or two, the effects aren't as material, but as you get older and you have multiple medications, the effects are larger. So there's a ton of clinical evidence as to what drugs work on what individuals with what enzymatic makeup. And so we're able to take this genomic information and give information to physicians back at the point of care as to what is the right medication makeup. So let's take, for example, we probably all had relatives that have maybe had an angioplasty or a stent put in. And so when you think about a stent being put in, it's metal that goes into your artery. And what has to happen is it has to properly clot. And if it improperly clots, it can block your blood vessel. Again, you'll have a heart attack within months. So you typically get a drug, so let's say it's Plavix. So Plavix is a blood thinner. So you take that typically for 9 months to a year after you've had a stent to ensure that it doesn't excessively clot and cause another heart attack. But if your enzymes don't properly metabolize Plavix, where essentially the liver enzyme has to activate it, and it doesn't have the ability to activate Plavix, what happens is it doesn't clot properly, and you will have a heart attack again in a month, 2 months, 3 months, and there won't be any sign of it, because it's really difficult to see if it's clotting properly.
And when that patient has a heart attack, they end up in the hospital. You all end up paying the bill. That gets very expensive for everyone. It's not good for the patient. It's not good for you all. And so you guys were able to do this genetic testing and figure out, are these drugs going to work in these patients, or do we need to do something to adjust their dose or make sure that they get the right thing and save everybody money, essentially?
Absolutely. So I think you described the outcomes that are horrific in those scenarios, and that do happen. But you're able to determine at the point of care with that test where there are alternatives to Plavix. Plavix is usually used because it's a generic, because it's easily accessible, it's lowest cost. But if there is a variant of that enzyme, there are a bit more costly therapeutics that are alternatives that are metabolized a bit differently that may work for that patient. That will definitely, even though it might be higher cost, it's definitely going to lower downstream costs.
Walk me through the finance. I mean, how much does it cost to run one of these tests, and how much do you guys end up saving as a result of this?
Sure. So a test like this, in terms of a panel for a genomic test like this, is about $240. This same test probably would have cost $2,400 maybe 5 years ago. This same test in 5 years literally might be $2 to $5. Maybe that's extreme, but I wouldn't be surprised. And so if we think about the typical patient who has 8 chronic conditions, on average, they're getting admitted to the hospital once a year, which this doesn't include kind of follow-up testing and everything. That's going to cost about $14,000. So even if you assume that let's say 15% have this variant, so
you have to test everybody.
Test everyone. So that's cost. So to test everyone, call it $1,200 for 6 patients, but only one of those patients it may be applicable to. So if you're able to prevent a hospital admission 20% of the time, that's, call it $3,000 in savings on that one person that would have paid the cost of the testing for all 6. Not to mention that that information is highly relevant forever for that individual patient.
So this is something that once you guys have done testing like this will kind of continue to accrue throughout the years in terms of the benefit. Are there other things like this that you guys are identifying, other kind of genetic variants that are key, that can be key drivings of savings or something like that for you all?
So nothing that we feel confident enough yet. Given our population, there's a lot of opportunities, at an earlier age, when you're a newborn, around cancer. At a later age, it's generally harder to determine which variants are actually going to have an effect, when you're 70 versus 30. Pharmacogenomics was the one where it was such a massive opportunity in terms of outcomes improvement. But what the exciting thing for us is, we're able to now collect this data. And as part of this partnership with patients we're creating, as we have insights in terms of what we think could be hypotheses, we can, on a retrospective basis, take this genomic data and see if there's correlations between other sorts of outcomes that they're having. So instead of speculatively acquiring samples and genetic data, there's a very specific use case as to why we're collecting it. We're doing it profitably in the interest of our customers, and we can start mining that to see if there's incremental opportunities that may not have been discovered yet.
Well, that's really interesting. I'm excited to hear what you guys have up next. Next on the panel is going to be Peter Rudiger of the Wall Street Journal. Vivek, thank you so much for speaking with us. It's been really interesting, and thank you to our audience.